Thank you very much for your kind introduction and welcome everybody to this section. And at first, let me congratulate with the previous speaker because of his huge collection of nice foreign bodies. So also we have in Italy this kind of problem. So, but let's talk about this topic today. I mean, the trauma of GI tract. As all we know, all of us people involved in emergency, trauma to the bowel or to the mesentery is not something very common, and it seems that accounts just for a few percentage of all the trauma involving the abdomen. And of course, a very low percentage of them with blunt abdominal injuries could have small bowel or mesenteric injuries too. But when we observe trauma to the GI tract, of course, in most of cases, we could observe also other kind of injuries to the rest of the abdominal organs. What kind of mechanism of injuries could cause trauma to the GI tract? We could have crash injuries, we could have shearing forces at some fixed sites of attachment, or we could have some burst injuries from an increase in endoluminal pressure inside the lumen. What about the crash injuries? Well, the crash injuries could result from an impact of a stationary object on the anterior abdominal wall that catches a kind of loop of the bowel between it and spine or other solid organ. And in this case, the duodenum and the transverse colon present at very higher risk with this kind of mechanism. The second kind of mechanism, I mean the shearing forces at some fixed site of attachment. In this case, some acquired adhesions and normal points of bowel fixation at the ligament heights and in the ileocecal junctions could serve as a kind of anchor point in shear injury, so that in case of trauma, a rapid acceleration could allow a mobile segment of the bowel to move rapidly away from some fixed point, causing, of course, the injury to the bowel itself. The last kind of injury, the burst injuries, occurs when the impact with the stationary objects, anatomical bowel, into the closed loop. So if the compression continues long enough, the pressures can rise to the point where the bowel wall may burst, resulting in perforation of the viscera. Of course, when a patient came to our attention with the trauma, abdominal trauma, of course, in case of acute abdomen, we could really observe trauma to the diaphragm or other parenchymal organ lesions, as well as hollow organ injuries, as well as the lesions of the fixation structures, because patients with the GI tract trauma are symptomatic patients in most of cases. We have to say that the small bowel is less vulnerable in trauma because of the low fixity to the parietal structures, and the duodenal-jejunal angle and the ileocecal valve are some kind of fixed structures with higher risk in blunt trauma. Regarding the colon, of course, in case of some determining factors, we could have a burst lesions or as well a direct trauma to the colon. We could also have a large parietal hematoma complications that cause the lesions of this intestinal segment, as well as we could observe some mesenteric laceration with infarcted necrosis as potential complication in this case. Well, in absence of other trauma or lesions to the remnant abdominal organs or some other vascular associated injuries, intestinal trauma could present and can cause various kinds of clinical symptomatology. So to make a diagnosis of a traumatic lesion to the small intestine in absence of the presence of free peritoneal air could be some kind of difficult. Despite the significant rate of bowel or mesenteric injuries following blunt abdominal trauma, and marked increase in mortality because of delayed diagnosis of bowel perforation. Physical setting in emergency could be very, very difficult in absence of very clear symptomatology because the classical triad of tenderness, rigidity of the abdominal wall, and absent abdominal sound occur just in 1/3 of series of patients, with presenting the most consistent findings on tenderness really are specific. So the appearance of signs and symptoms could delay also several hours from the time of injuries to make a correct diagnosis of that. Let me show you some real injuries, what is the real appearance of that, from surgical findings, of course. As you can appreciate here, there's a mesenteric laceration over here. In this other case, we have small bowel perforation from trauma. Or in this case, we can appreciate laceration, transection of the small bowel by trauma. And of course, this is a small bowel contusion, either from blunt trauma. Whereas in this case, this is the appearance, the real appearance of large bowel contusion from blunt trauma. This is a case of small bowel burst laceration. And in this other case, you can appreciate multiple lesions from burst injury of the small bowel. Whereas this one is a mesenteric laceration with intestinal ischemia of the ileum in a deceleration trauma. Well, what about the study protocol? Of course, I'm talking about MDCT because as nowadays this is the main imaging method in trauma in an emergency. Well, in case of to perform a CT examination, of course, also in suspected lesions to the GI tract, we do not administer any kind of contrast medium at the beginning. But in all cases, we administer intravenous contrast medium. And we operate a dynamic multiphases acquisition. So, I mean, multiphase, pre-contrast, arterial, and venous at least. And very, very important are the multiplanary formations, a dedicated workstation in the post-op processing. What about the endoluminal contrast media? Well, it is already stated that also in absence of this kind of administration of contrast medium, we could perform a correct diagnosis, and so the exam without any kind of oral administration of contrast media could be considered as adequate for depiction of bowel and mesenteric injuries that require surgical repair. But what are the signs that we are looking for with CT exam? Of course, we must pay attention to the presence of bowel wall abnormalities and discontinuity with the evidence, if any, transection points, laceration points. Of course, we must take care and look for the presence of free peritoneal air or free air in the retroperitoneum. Of course, we must take care about the evidence of focal bowel wall thickening, or mural hematoma, or pneumatosis, parietal pneumatosis, as well as the evidence of mesenteric hematoma that we could miss sometimes. And as well, we have to look for any kind of abnormal mural enhancement of the bowel or the sensitization of intravenous contrast medium from mesenteric vessels or some kind of triangle-shaped mesenteric fluid collections that could be, you know, much more in cases correlated to the presence of mural hematoma. Of course, we must take care about the evidence of sentinel, any kind of sentinel close sign, or if we will, in a kind of follow-up administer oral contrast medium, we must take care of signs of extravasation from the lumen. What kind of lesions of findings we could have in a GI trauma? There is a kind of range. We could have functional disorders at the beginning. We could have the evidence of contusion of GI tract, of the mural hematoma, or laceration, or as well as active bleeding. Let me show you different cases. So regarding the functional disorders, like in this case, well, this is a case in which you can appreciate the large bleeding lesions of the liver from trauma and the presence of hemoperitoneum. And you can appreciate the small bowel that is totally collapsed from spastic ileus. So it's just a neurogenic cancer, bowel wall collapsed. Other case, bowel wall collapsed with normal enhancement, caused by, in which patient we had a pelvic trauma with hematoma in the retroperitoneum and signs of active bleeding in the gluteus region. In this other case, we have, as a functional disorder, the appearance of invagination, the so-called cold invagination. I mean, it's just functional. It does not mean that the intestine is blocked, is obstructed. In this patient with major trauma, he fell down from maybe a second floor, I think so, with, of course, chest injuries too. And this is the follow-up exam when the patient stays in the intensive care unit. We administer peroral conscious medium to look at, invagination. And we can appreciate the passage of the matter without any kind of closed obstruction. And it is a very late follow-up exam in which the intussusception is resolved itself. This other case, it's a case of intussusception of cold intussusception, I mean non-obstructive, of the large bowel caused by in patients with multiple pelvic fractures. Oh, sorry. Oh, next. Technical problem solved. Okay, thank you. Sorry. So this is a case of non-occlusive intussusception, another case in patient with abdominal trauma. And this is the zone of the cold intussusception. Well, regarding other kind of trauma, this is a case of gastric wall mucosal hematoma in patient with blunt trauma. In this other case, it's a gastric wall hematoma over here. In this other case, we can appreciate the mesocolon hematoma from blunt trauma. And this is also a case of a mesocolon hematoma, but much more larger and evident. In this other case, this is pre-contrast of a mesocolon hematoma too, in this region. And this is the appearance after intravenous contrast enhancement. In this first exam, we do not have any kind of signs of bleeding, active bleeding, but several days after, situation little changed with evidence of pseudoaneurysm from signs of bleeding over here. So, in this other case, this is a case of a mesentery hematoma at the root of the mesentery with signs of active bleeding over here. This other case, mesentery hematoma in major pelvic trauma with evidence of hemoperitoneum and mesentery hematoma too from trauma, with signs, of course, of actively bleeding in the pelvis. In this other case, it was a very dramatic case. You can appreciate the massive hemoperitoneum from mesentery dissection and laceration. This is a pre-contrast exam. There is blood everywhere. And after contrast medium, you can appreciate signs of active bleeding, much more evident in multiple points with a complete dissection of the mesentery from his root. This is the late scan with presence of massive extravasation of contrast medium. and of course the presence of free peritoneal air. Let me show you different cases. In this case, in patients with blunt trauma, this is the first exam, and you can appreciate that there was no other signs of abdominal organ injuries, but we can appreciate some small amounts of fluid in the abdomen. Very small amount. And look at these loops, the appearance. It appears like slightly thickened, but not something massive, you know. Well, one day later, the patient developed abdominal symptomatology, much more evident. We performed another CT exam, and we could appreciate the presence of a small bubble of gas outside these small bowel loops, and of course the presence of free peritoneal air from perforation. It's a case of small bowel perforation from blunt trauma with delayed presentation. In this other case, this is a patient with blunt trauma. This is the first CT exam. And also in this case, you can appreciate the kind of thickening of this group of loops with some kind of fluid outside. 2 days later, of course, the patient developed a much more evident abdominal symptomatology with evidence of fluid and gaseous collection outside the same group of loops that I showed you before from jejunal perforation. So please take care of that and perform a late examination, follow-up examination in case which the symptomatology of the patient gets worse. So this other case, this is a blunt trauma of the serosal surface of the stomach, caused by, of course, blunt trauma. You can appreciate small bubble of gas outside the lumen and the evidence of hematoma surrounding the viscus. In this other case, it was a cecal burst lesion from blunt trauma. In this case, we had very multiple bowel perforation from bowel trauma, so this was a kind of a surgical diagnosis because at CT we just had evidence of free peritoneal air everywhere. In this other case, this is a case of gastric trauma, gastric fundus trauma from burst lesion, and here you can appreciate some hyperdense, inhomogeneous matter. Do you know what there are, these findings related to? Well, I have to say this was a boy that had a car crash after having dinner. So his stomach was fully of food. And so this is food. And in particular, this is a kind of a pasta outside, you know, the lacerated stomach. And this is the surgical evidence of the burst of the cecal funds. This other case, it is a case of multiparenteric perforation from blunt trauma. You can look at the presence of free peritoneal air everywhere. In this other case, I can show you the cecal rupture for major pelvic trauma, very complex trauma, multi-fragment trauma. And this was the evidence of surgery. These are bones, and this is the parietal wall of cecum. This other case of cecal burst with delayed duodenal hematoma. Here, a delayed scan. This is a duodenal hematoma from trauma. In this other case, we can appreciate, also in patients with abdominal trauma, active bleeding of the jejunal. And in this other case, you can appreciate some gastroenteric lesions from blunt trauma with GI and splenic infarction, and of course also the stomach. You can appreciate also a kind of contusion of pancreatic tail and infarction also of the spleen. So, in conclusion, of course, MDCT can be considered as an effective imaging method to make diagnosis to the GI tract and the mesentery, but we must pay attention to a correct time and acquisition parameter. And of course, we must take care of the appearance of the bowel. We must be very exact and precise regarding the presence of swelling, parietal enhancement, the presence of free peritoneal air or retroperitoneal air, and the signs of active bleeding. And please share any doubt or concerning diagnosis with the referring clinician or surgeon. Thank you for your attention.
Thank you very much, Dr. Romano, for a great collection of gastrointestinal tract injury cases. Is there any question from the audience? Any question? Okay, so I have a question. So, which protocol would you suggest to look for gastrointestinal tract infection? Injury for?
As a first protocol, just administration of intravenous contrast medium after a pre-contrast phase, and we perform arterial and venous phase at the beginning.
Do you recommend a delayed phase? What about delayed phase?
Delayed phase in several cases. Delayed phase, just arterial and portal.
Okay. Any other questions? Okay. Then we can proceed to the next session, which is liver, splenic, and pancreatic traumas.
Thank you once again. So, as we all know, trauma is the main cause of death in people, in young people. But whereas the main cause of death is related, most cases, to brain injury, main cause of preventable death is related to abdominal trauma and to failure in stop bleeding. What about the imaging method that we could have? Of course, we can approach the patient with trauma by sonography, by MDCT, or by angiography. But what regarding the imaging modality and what imaging finding to look for what kind of organ and what kind of injury? So it is strongly important the presence and the correct diagnostic triage according to the clinical status of the patients with trauma, because patients that are hemodynamically stable with no clinical findings of severity and without peritoneal fluid at sonography, of course they could undergo a clinical follow-up, whereas the unstable patients with evidence of peritoneal fluid at sonography, they could undergo directly to laparotomy, or patients that are not stable with high suspicion of active bleeding lesions, they could undergo angiography. However, nowadays, CT imaging could be a one-stop shop for everything, and nowadays it can be considered the most comprehensive imaging method to study patients with major trauma after maybe a basic exam with sonography. And in effect, CT examination is strongly effective also with the angiographic phase in detection of parenchymal or organ injury, effective in detection of presence of active bleeding, and it could allow a very wide whole body scanning that could also, of course, be extremely useful also to detect spine and skeletal injury. What about the imaging protocol of patients with very big trauma? Well, of course, also in this case, we do not administer any kind of peroral contrast medium, but in all cases, we administer intravenous contrast medium, performing a dynamic multiphasic acquisition, usually pre-contrast, arterial, portal, and late scan, in presence, of course, of peritoneal fluid evidence. And also in this case, the multiplanar reconstruction with the post-processing are very crucial, and so please pay attention to the back reconstruction because they are very important to perform a very nice and useful imaging multiplanar. So, considering the various organs which we are looking for this morning, starting with the liver, as you can appreciate, blunt trauma of the liver is something not rare, is very common, could be very common, and represent maybe 1/3 of 1% of all patients with presenting abdominal organ injuries. And usually the lesion to the liver is not unique. I mean, maybe the isolated hepatic lesions are very rare, and in most of cases we can appreciate also lesions to the other abdominal organs and viscera. What regarding the mechanism of injury? Well, the right hepatic lobe is a very frequent site of injury. Why? Because it is the more huge portion of the liver parenchyma, so the posterior superior hepatic segments are very close to fixed anatomical structures such as ribs or spine that could have a great role, important role in determining the lesion. Whereas the coronal ligament insection in this parenchymal region can improve the effect of acceleration and deceleration mechanism. And associated lesions usually are costal fractures or lesser contusion of the inferior right pulmonary lobe. We could appreciate hemothorax too, pneumothorax, as well as renal or adrenal lesions. The trauma to the left hepatic lobe are very rare, usually correlated to the direct impact of the superior abdomen, such as we can appreciate in car crash with a comprehensive effect on thorax and abdomen, and some associated lesions to left hepatic lobe injuries and correlated to this mechanism. So we could appreciate also as additional findings, sternal fractures or lesion to the pancreas or to the GI tract as well as to the myocardium. What regarding the classification? The classic CT classification from Professor Mirvi's school in Baltimore considers a grading of hepatic injuries that could vary from the evidence of capsular avulsion, superficial laceration, subcapsular hematoma less than 1 centimeter thickness, or periportal thickening. All these lesions could be considered as grade 1 to very late, stage of disease with parenchymal organ fragmentation and evidence of avulsion of the vascular peduncle in case of grade 4 hepatic injuries. What to searching for in case of liver trauma? Well, we can appreciate the presence of periportal thickening. This is a very, early and first stage of disease, very less important lesion. We can appreciate contusion of the liver or subcapsular or central hematoma inside the organ. We can appreciate streaking or complex lacerations, or in late stage, in very big lesions, important lesions, so we can appreciate fragmentation of the organ with the avulsion on the vascular hepatic peduncle. Let me show you some cases. In this case, we have a very, small lesion of the fourth hepatic segment. In this other case, we have a lesion of the right hepatic lobe. In this other lesion, it's a kind of small bear claws lesion of the right hepatic lobe. In this other case, we also have a lesion, but is of a higher degree with, fragmentation of this segment and some associated lesions to the adrenal gland and on the right kidney. And of course, coronal reformation could give us, a much more evidence of the real consistence of the lesion. In this other case, we also have a lesion of the right hepatic lobe. And I don't know here, but in Europe, and especially in Italy, we have a very wide use of contrast-enhanced ultrasound to follow up patients treated with conservative matter of the lesion, of the abdominal organ lesions, like in this case. We made the follow-up with CUS, contrast-enhanced ultrasound. This other case, you can appreciate this lesion. In this case, we have associated with biloma, with bile extravasation and formation several days after the traumatic event of some abscess inside that grew up, and it was treated with percutaneous drainage. In this other case, very important liver trauma with active bleeding inside. This other case, evidence of multiple sites of bleeding inside the right hepatic lobe. And it was, of course, a major lesion of the liver. But what regarding spleen? Well, as all we know, lesions from trauma to the spleen are very, very common, and they could be managed either in surgical, either in conservative treatment, depending from the kind of injuries that the organs have. We can consider 5 grades of injury according to the AST scale, from grade 1, from subcapsular hematoma, to grade 5 with shattered spleen with active extravasation, infarction, or vascular injury or the hilum. But of course, we can consider too the CT injury severity grade syndrome Splenic Trauma made by Professor Benvis several years ago, but still, actual. We can grade the lesions of the spleen from grade 1 to grade 4. I mean, from capsular avulsion to fragmented devascularization spleen. And of course, the incidence of surgery may go up with severity of injury, and of course, there is a significant number of patients that present a high-grade splenic injuries that could be, of course, successfully managed in a non-operative way, but it is already true that certain numbers of patients with low-grade splenic damage could fail the conservative treatment and must undergo surgery anyway. And of course, the presence of active bleeding or the presence of pseudoaneurysm must be associated classically with an increased failure rate of attempted conservative management of splenic trauma, whereas a more complete grading scale of splenic injury may include characterization, of course, of correct vascular injury into active splenic hemorrhage, or as well continued injury by using, of course, the dual phase CT. What about imaging findings? In this case, in case of patient, you can appreciate the trauma to the chest too and to the left pelvis. You can appreciate contusion of the spleen here. In this other case, this is a case with laceration of the spleen from trauma. No other organ associated with this kind of lesion. And in this other lesion is a more, large laceration of the splenic parenchyma from brain trauma. In this other case, you can appreciate also contusion of the left lung associated to the lesion of the spleen from trauma. Well, evident also in coronal reformation and the presence, of course, of hemoperitoneum. The patient was submitted to surgery. And please pay attention that it is not correct in any case to have associated lesions to the ribs in case of splenic trauma. This other case, major lesion with active bleeding of the spleen from trauma. In this other case, of course, presence of active bleeding inside. This is a case of shattered spleen. You can appreciate the presence of, the presence of multiple sites of hemorrhage. In this other case, you can appreciate the presence of active bleeding, well evident either in reformed images. And this is the post-op finding, and you can appreciate also the trauma of the left adrenal gland. These are the patient with the chest, of course, lesions and the false shattered spleen with infected area and the presence of active bleeding. We could have also the chance to image patients not immediately, like in this case, the patient came to our attention several days after brain trauma, and we could just appreciate the hematoma inside from laceration, previous laceration inside the organ. In this other case, we have, of course, a complicated hematoma from previous blunt trauma with the abscess, formation of abscess. Please note the small bowel gas. this is the appearance, where's the appearance of chronic hematoma of the spleen. You can also note some kind of calcification here. Well, the non-surgical management of abdominal traumatic lesion can imply the use of hemostatic agent. I don't know here, but in Italy, we sometimes use the sealant, and the sealant is an agent containing thrombin and collagen with proven hemostatic efficiency if applied into a bleeding site. And we must be, used to see, to look at images of patients in post-op. In which the surgeons put on the sealants, like in this case. And this is the appearance of the sealant to treat conservatively the splenic lesion. As well, trauma could imply the rupture of the spleen if in presence of any kind of pathology, like in this case. The spleen was involved from multiple lesions from lymphoma, and it was the patient underwent blunt trauma, and of course he had the lesions of the spleen with rupture. Or this other case, you can just appreciate the evidence of very monohomogeneous and enlarged spleen that was pathologic, and you can also appreciate the trauma to the pancreatic tail. You can have also in this case multiple lesions to the liver, and of course to the spleen, and of course also on the pancreatic tail, like here. And this case introduced me to the last topic, I mean the lesion to the pancreas. And so we know that blunt trauma to the pancreas is not common. It is quietly a kind of rare and sometimes could be not easy to diagnose. Of course, also with the pancreas, we could appreciate we could have a varying grading scale from simple superficial contusion to severe pancreatic injury without disruption. And the spectrum of injury could varies from hematoma to laceration of various kind with a deep stage of massive disruption of the pancreas. And of course, the fractures most commonly occur in pancreatic head or body, whereas the pancreas overlies the spine, so it is much more subject to trauma from car crash. But of course, we could also appreciate fractures of the head of the tail. Let me show you some cases. This is a case of patients with minor contusion to the pancreatic tail over here. Of course, we had also associated lesion of the left kidney from trauma. This is the appearance of a large pancreatic head hematoma from trauma. And this is the appearance of a large pancreatic body contusion with, of course, collection of fluid in the peri-pancreatic space. This is a minor laceration of the pancreatic tail, whereas this is a complete fracture of the pancreatic tail over here. This is a kind of transaction. This is a very huge pancreatic body fracture, whereas this is a case of another case of pancreatic body fractures well evident. This is a double case of head and body fracture of the pancreas. These are from the archive of Professor Mirves that borrowed me these cases, as well as this one, in which we could appreciate the pancreatic head laceration associated with the duodenal rupture. Well, we could have a complication in trauma to the pancreas, and most commonly we had pancreatitis, like in this case. In this other case, we had lesions, of course, of the liver and of the neck laceration with, of course, also tail contusion. And this is the appearance of multiplanar reconstruction. And of course, we had also a delayed complicated pancreatitis. In this other case, this is the case of a tail fracture in patients with splenic hematoma, I remember this case because it was one of my first cases when I started to do night shift in my hospital. She is a young girl. She was now she is older, and she had this kind of lesions, lateral lesions of the spleen, and this kind of lesion with transection of the pancreatic tail. And please pay attention that at admission the amylase rate was normal. And of course, also in this case, there is no evidence of ribs trauma. This is the image from surgery of the same patient with transection. This is the spleen, and this is the pancreatic tail resected because transected completely. While some complications occurred in the same patient, I mean, starting from the abscess in the splenic site of the intervention, and 6 days after surgery, there were a very high level in amylase. And she also undergoes a low-flow pancreatic fistula and digestive hemorrhage from duodenal ulceration. And, you know, usually low-flow fistula tends to close spontaneously. In this case, a very small drainage was put in the patients. And 2 weeks after surgery, we can appreciate a kind of solving of the large collection that was evident in the splenic site. So also in this case, in major trauma, MDCT can be considered as an effective imaging method to diagnose any kind of parenchymal organ injuries. But also in this case, we must pay attention to the correct timing and acquisition parameter of the exam. And of course, we must take care not just to the appearance of the organ itself, but also to the other findings that we can appreciate in the abdomen, also related to the GI tract or other organs that at the beginning do not present any kind of alterations. And please sharing it out concerning diagnosis with the referring clinician and surgeon also in this case. Thank you for your attention.